Hello, good evening, and welcome to Cafdil Healthcare on Cafdil Television. Tonight we have a special discussion. And most of the time, some diseases, some people call it old time disease, and so they don't really focus on those diseases. But let me tell you, the fact is that it is killing a lot of people. What am I talking about? I'm talking about tuberculosis or tuberculosis, simply call it TB. That is exactly what we're going to discuss. Not long ago, we celebrated World TB Day, and so it's worth discussing tonight here on Capital Television. My name is Kojo Arthur. Let me also remind you that we are live on Facebook, Capital Cape Coast, and also YouTube, Capital EDU. My guests are seated already, and I will introduce them right after this break. Stay tuned.
Tuberculosis, or TB, an infectious disease that may affect almost any tissue of the body, especially the lungs, caused by the organism Mycobacterium tuberculosis. About 10 million people worldwide were sick with TB in 2015, and about 1.8 million people died from TB worldwide in 2015, according to the World Health Organization. What are the causes of tuberculosis? All cases of TB are passed from person to person via droplets. When someone with TB infection coughs, sneezes, or talks, tiny droplets of saliva or mucus are expelled into the air, which can be inhaled by another person. Once infectious particles reach the alveoli, the small sac-like structures in the air spaces in the lungs, another cell called the macrophage engulfs the TB bacteria. Then the bacteria are transmitted to the lymphatic system and bloodstream, and spread to other organs occurs. The bacteria further multiply in organs that have high oxygen pressures, such as the upper lobes of the lungs, the kidneys, bone marrow, and meninges, the membrane-like coverings of the brain and spinal cord. Latent TB. You have the germs in your body, but your immune system stops them from spreading. That means you don't have any symptoms and you're not contagious. But the infection is still alive in your body and can one day become active. Signs and symptoms. A cough that lasts more than 3 weeks. Chest pain. Coughing up blood. Feeling tired all the time. Night sweats. Chills. Fever. Loss of appetite. Weight loss. Diagnosis. During the physical exam, your doctor will check your lymph nodes for swelling and use a stethoscope to listen carefully to the sounds your lungs make while you breathe. Blood tests. Blood tests may be used to confirm or rule out latent or active tuberculosis. These tests are sophisticated technology to measure your immune system's reaction to TB bacteria. Imaging tests. If you've had a positive skin test, your doctor is likely to order a chest X-ray or a CT scan. This may show white spots in your lungs where your immune system has walled off TB bacteria, or it may reveal changes in your lungs caused by active tuberculosis. Sputum tests. If your chest X-ray shows signs of tuberculosis, your doctor may take samples of your sputum, the mucus that comes up when you cough. The samples are tested for TB bacteria. Treatment. With the proper treatment, tuberculosis is almost always curable. Doctors prescribe antibiotics to kill the bacteria that cause it. You'll need to take them for 6 to 9 months. What medications you take and how long you'll have to take them depends on which works to eradicate your TB. Sometimes antibiotics used to treat the disease don't work. Doctors call this drug-resistant TB. If you have this form of the disease, you may need to take stronger medications for longer. The main drugs for tuberculosis are ethambutol, isoniazid, pyrazinamide, rifampin.
Welcome back. If you just join us, this is Cafdil Healthcare on Cafdil Television, and we are discussing tuberculosis, TB for short. And like I said, we are live on Facebook and also YouTube. Go like and share and leave your comment or whatever. We shall definitely read them for you. My guests tonight are Peter Nab, is a disease control officer from Cape Coast Teaching Hospital. And Sandra Adai, she is also a public health nurse, right? All right. Then Constance Abuga. Constance Abuga. She is a senior staff nurse, infectious disease unit,
yes.
Cape Coast Teaching Hospital. You are welcome. Thank you for joining me tonight.
Thank you.
All right, so let me start. They said ladies first, but here we are going to start men first because the ladies are two. So let me start from you now. Tuberculosis. To be frank with you, I personally have not seen someone being infected with this disease. That is the truth. So personally, I don't know how it looks like. Perhaps our viewers, some may also not know how it looks like. So I want you to tell us, or before you tell us what TB is, let us know the current status of TB in Ghana, especially in Central region here.
Okay. All right. Thank you so much for this opportunity. Actually, we are talking about this because, yes,
not long ago,
that was 24th March. The whole world marked the day, World TB Day. The reason why it's marked on that day is because that was the day that Robert Koch discovered or announced that he has found a TB bacilli. That was in 1882.
Robert
Koch. Yeah, he discovered the bacilli that caused TB. And so from that time, every 24th March is recognized globally as World TB Day. Now, that brings us to the next issue about Ghana status and then in the Central region perspective. Okay, so tuberculosis in global standards, we have had a normal or a consistent increase in TB cases for a while now. But then the death rates too are also gradually going down because of effective treatment. But then another part of it too is drug resistance. Those that are drug resistant to TB, they are rather on the rise and it's a big concern. That's the global picture. When you come to Ghana, we've been classified as unsustainable and then successfully a group. So I will explain it for a while. Or low notification, high successful group. We have, experts have been able to check and say that, okay, this is the population or number of people in the country that are suffering from TB based on surveys. It is estimated that about 44,000 Ghanaians are suffering from TB annually. But Ghana, we have been able to detect less than 50% of those cases. But then with the number that we are able to detect, we are able to cure or treat successfully about 90% of them. So at least the ones we are able to detect, we are able to solve their problem. So that's why the high success part is coming from. But the unsustainable part or low notification part is because we are only able to detect less than 50% of the true cases that are in the system. When you bring it down to Ghana's Central region status, Central region is part of what we call endemic regions for TB. It means we record high numbers of TB cases. The death rates too are usually similar because most people too, they report late and end up dying. So it's among the high death rates areas. Aside that too, we are also part of the people that also record the multi-drug resistant or drug resistant TB cases as well. So that's just a brief concept about it. But then you asked before this that then what is TB like?
Yes.
Or how do
what is it here?
So it's a disease that has been there for long. So as I said, the bacilli itself was discovered in 1882. from that time till now, they've been trying to diagnose it, and people have suffered with it before even the bacilli was identified. The main issue is that it presents in the form of cough. That's the common one people know. But it's an infectious disease. And as an infectious disease, it's caused by the bacteria, Mycobacterium tuberculosis, where an individual who has it coughs or sneezes. And the cough is not a one-time thing like normal catarrh. It is persistent. And usually in the night it's heavier. It makes the person to lose weight, have chest pains, and then can transmit to another person, and the person to show the symptoms. If I'm to put it in some those are
all right. So in the central region, I mean, or Cape Coast and its environs, it's rising.
Yeah,
it's rising. The cases
are rising, but then we can associate it to our capacity to detect or diagnose more. As I said, we have a lot in the communities.
Okay.
And we are only detecting less than 50%. So when we are detecting more, it doesn't mean that the cases are actually rising. It means that we are able to detect more cases that we should have detected. So
it said it increases in the night.
The cough. Yes, mostly the person sleeps in the night. That's when they cough heavily.
Why?
Okay, so that brings us to another aspect. You know, it's something that affects the chest region. And when it affects the chest region, it irritates the throat. And then fluid usually is accumulated there. When the person lies down in the night and is not using pillow to sit upright or adjust in a position that it usually triggers back to the throat region, which makes the person get irritation and they cough severely.
Okay.
So in the treatment course, we usually advise them to use pillows to raise their back. When you come to the hospital, you realize that the TB patients are not sleeping on straight beds, but then it's elevated, so that it is to relieve them from getting the irritation for the cough.
Do they have a specific angle that?
Oh, no. It's just something comfortable that you can sleep and reduce the cough as well.
And usually, to add
Yes.
Usually we position them from 45 degrees to 90 degrees.
Okay.
Yes. That helps to open the lungs to enable them to have adequate gas exchange.
But are they able to sleep if you sleep like 45 degrees?
Yes. We don't just adjust it based on our knowledge. We ask the patient if they are comfortable with the position. Yes.
All right. Okay, so then what are the key warning signs and symptoms of this active TB?
Okay. So for us to be able to know whether a patient has TB or any other thing, we have to monitor the patient for certain or cardinal signs and symptoms that have to do with just TB. And some of these are cough, like he said. And this cough is very persistent, usually beyond 2 weeks. So the patient has to cough for more than 2 weeks for us to suggest
continuous.
Yes, continuous for at least 2 weeks or more than 2 weeks for us to know or think that the patient may be having TB. And also the patient would lose weight drastically within the period. So maybe for the first month, the person was weighing maybe 90 kilos. Within the next month, the patient would have lost like 20 kilos. It's sudden and very rapid. That will also suggest that the patient is likely to have the disease TB. And also others can be night sweat, excessive sweat in the night. And the person will also have bloody cough. So while they cough, they bring out blood. You know, when you have a normal cold, you may just cough normally. But with a TB case, they may bring out blood as well.
Okay. You want to add something?
Yes. Okay, so all those they were talking about, I think with the TB, we have the ones that affect the pulmonary and the extra. So when you have the pulmonary TB, that is whereby you have these signs and symptoms. So with the extra one, normally, because you don't cough, you wouldn't know you have TB. So you can have this for a longer period. By the time we will diagnose you of TB, which is extrapulmonary, then it has gotten to a stage where the management will be very cumbersome. So the TB, not all the TB comes with cough and those signs and symptoms.
So some may have TB without knowing that they have TB.
With the pulmonary, is easy to diagnose because of the cough. Because all we know is TB comes with coughing, but we have other ones, which is it's affecting other parts of the body. It can affect the spine, the bone, the brain, and that one it doesn't cough because it's not affecting the lungs. So those ones are very, very difficult to know or to be diagnosed.
So then at what point should I see a doctor? Because cough is cough. Night sweat. This climate is very hot. A lot of people sweat at this time because of the weather. So if I should go and sleep and I'll be sweating, like what you were saying, I may have TB, maybe, I don't know. So at what point should I see a doctor?
That's why we always create awareness of checkups. You don't need to be sick before you come to the hospital. So maybe this is not usual of you. You don't normally sweat at night, but now you are sweating. You feel, you think you're not sick, but it's so unusual. So you can contact any health worker so that if appropriately any investigation has to be done, you will do it to rule out whatever it's causing. You should also know that it's not just only TB that shows up these signs and symptoms. There are other conditions that also shows up these signs and symptoms. So you can rule out to know what is really bothering you.
So how is it diagnosed actually?
Okay, so with the TB, when you are coughing or you come with cough, we have GeneSpect test. You produce sputum for us, we take you to the lab. Others too, they can use X-ray. We take the chest X-ray to know what is going on. And with the TB test, GeneSpect, most they are free. They are free.
All the tests are free.
Most of them, because TB itself, treatment and most of its activities, they are free.
Just like HIV.
Just like HIV. There are tests, there are treatments. From the first day to the last day, they are free. So when you come for screening, it's always free. Yes.
But do you have some kind of test apparatus where if you are home, you can test it yourself to see whether you are being infected with?
For now, I don't think we have that one. You just need to come to the hospital for the lab technicians to take the necessary things they need to take from you to do the investigation or to see the doctor. The doctor will determine which investigation you will need to undergo. So you can't detect that one whilst you're in the house, whether you have TB or not. Someone can call for more than a month, but you can come to do the test and it's not TB. So you just need to walk in to know what is wrong with you. You can't detect that you have TB because you've been coughing at home or you're coughing blood, so it is TB. It can be any other thing. So you can't detect TB whilst you're in the house.
Okay.
Now, okay.
To add a little to what she said, regarding the extrapulmonary TB, usually the patient will not cough for us to know or even suspect TB. But the patient may come to the hospital with issues of severe abdominal pain because let's assume it's in the abdomen. The patient is going to start complaining of pain in the abdomen because of the fluid that is being accumulated there and other places as well, like the bone and the spine. And for us to be able to test that, if you do a normal GeneSpect with a sputum, you're not going to get a positive result. So you have to tap the fluid at the location of the infection. So if it's the abdomen, you have to tap the fluid that is being accumulated there and for it to be tested before you can detect what it is. But if anybody that is suspected of TB is given only sputum, then you're going to continuously get negative results. Or if we rely solely on just the x-rays, we may end up misdiagnosing the patient.
But now, how does this? You said it's infectious, right?
Yeah,
so how
it's
does
infectious.
it spread?
Okay.
If someone has it, then I just want to shake their hands or something.
Okay.
Can I also catch it? How does it actually spread? So
Okay.
we will know how to deal with.
All right. In spreading, it means that it has to come from somebody who has the disease already, and that's an active person. That's someone coughing. Now, we've all sneezed before. When you sneeze, you attempt to cover your mouth, and then you end up having some droplets on your hand. It's that kind of medium that the TB uses. It uses droplet infection, or is said to be transmitted through droplet infection. So, as somebody is infected with TB, sneezes, coughs, or even talks, and then the droplets come out, anyone who is around them that is not wearing a mask and inhales that can get infected. The second issue is that in a closed environment, like here, if I should be coughing and I don't close my mouth or sneeze, anyone closer to me who inhales that droplet infection gets it. Okay, aside that too, they usually, for the contaminants, it's not usually a big deal unless it is really, what's the name? How should I put it? It's not a usual form of transmission. It doesn't mean it doesn't transmit, but it's not something that is so high or common like the sneezing or the coughing and those ones. So that's the main issue.
All right.
So you mentioned something about
like if someone is being infected with has it, and you want to shake or use, because when HIV emerged, we were warned not to share the same cup, shake hands, even talk to them. I mean, there's common things that we were warned not to share with them.
Not to.
Is it the same as TB?
No. So TB has some special issues. TB, the HIV, a lot of misconceptions. Most of those things are misconceptions. It's a way of stigmatization. So, but people usually will still stick around with it. But then, assuming I shake hands with TB patients, we've been touching or holding hands with TB patients, nothing happens. The only main issue is that you have to wash your hands after, when you are done. The issue being that most of us, we are Ghanaians, right? When I'm to cough, the cough etiquette says I should use my elbow to cover my mouth and cough. Mostly, we instantaneously go this way, use hand to cover the mouth. The droplets is left on the hand. I shake somebody, then the person also uses on the nose or something. But then the main issue is that we want to cut that transmission where the person sneezes directly onto somebody. The droplet, the hand ones and those ones are not significant enough. At first, we used to be talking about not sharing food, what's the name? Cutlery and other things. It's because of the issues of the contaminant, the droplets on it. But the transmission is also very low on it. But then, to make people safe, we just say that you allow the person to have their own cutlery, so that you don't associate it on that you shared bowl with this person. But that's not how TB is transmitted. As I said, I have to cough, sneeze, or talk in a way that the droplets that you see, it comes out in the air and you inhale it.
How long does it stay in the air?
It depends on the environment. If you are in an air-conditioned room, it's already moist. Whatever you release into it suspends in the air. Books will tell you around 30 to 45 minutes because it's still wet. So assuming, let's take it that we are in a condition that is so wet. If you sneeze here, it's understandable that it's inside there. But then in a dry place, within 5 to 10 minutes, once the droplet, I have to say, you sneeze on your hand, within 5 to 10 minutes, and the place is dry. You don't even see it. It's gone.
But the bacteria will still be there.
No. Yeah, it needs that kind of moist environment to sustain it.
Okay.
That's the main issue.
Sandra, do we have what you call latent infection and active TB?
Okay. So with the latent, we have some people, they are carriers. They have the bacteria in them, but then it's not causing any harm. So within a period of time, once their immune systems are strong, it can wear off. It wouldn't cause any harm to them.
Are they those that we call they are asymptomatic?
Yes,
somehow.
Yeah, they don't show any signs and symptoms because it's not causing any harm to the body.
They are the latent.
Yes, please. They are the latent. So we have those people there, and sometimes some people, they will need to be put on some medications. Others too, they don't need any medication. With their immune system, with time, it will go, because there are instances, most of us, we get some bacteria and our immune system flushes them away without us knowing. So it all boils up to us building up our immune system, and the active ones are those ones which causes alarm.
So who is at risk of progressing from one to the other?
Okay, so if you have the bacteria in you, your immune system is not fighting, then gradually it can proceed to active. If you are not doing regular checkup to know you're static, it can progress to active TB. So when you become active, then you'll be diagnosed of TB. Then you need to be treated.
I want to add on to what she has already mentioned regarding the latent and the active TB. Yes. So with the latent TB, like she said, it doesn't show it. The person has the bacilli, has been exposed to the bacilli. However, they don't show any signs and symptoms because the immune system has been able to fight it, not like destroyed it, but kind of subdued it, like encapsulated it, so it's unable to cause any harm to the person. So if the person does any test like chest X-ray, sputum test, or any other test regarding or relating to TB, it all comes out negative, even though the person has the bacilli in the system. The only one they can test positive to is the Mantoux test, where something is injected into their skin and all of that. That's a whole different test. But usually with the other major tests that we do, it's all negative for people with latent TB. But with those with active TB, they have the infection and they show the signs and symptoms of the infection. And they are also able to transmit it to other people, unlike the latent TB.
So latent, you cannot transmit?
No.
Oh,
you cannot transmit it.
Then some people should go and check.
So it's
whether they are latent.
So it's under what the literature says that we are almost 80% of us are carrying TB in one form or other because we
come again.
About 80% are carrying TB or have been exposed to TB. If you think you are not part, let me give these scenarios, then you can take yourself whether you sat in a car that somebody has coughed or sneezed closer to you, whether you have somebody in the house who has coughed for a while whilst you did not know what was happening. If after all this you can still mark yourself absent from this group, then you are part of the 20.
Okay.
So in all this, because we are in an endemic area, most of us, that's why literature says 80%, have been exposed to it.
Yes.
The good thing is that our immune system is able to fight it. But then for the especially for even health workers who are exposed to, say you are supposed to even look after 6 people, so indirectly it's those who are having it that you end up being exposed to. Close to 90% are said to be exposed to. But then when you now come to people getting or developing the disease, as they mentioned, immunocompromised people, HIV, cancer, people with diabetes, hypertension, things that make you fall, then it will take advantage. Children, they are also another, because their immune system is low. Then somebody who is in contact with a positive case, so take it that in a household somebody is having TB, has not been put on treatment, but then you are exposed to that person, probably as a partner, because it's in the night the person will cough, and once the person starts coughing heavily, it's not then that you run away. So those are the groups of people who are highly at risk of getting tuberculosis.
All right.
And also those in the prisons, or generally
Confined
those in
areas.
confined areas. So you see, if someone gets TB in a prison,
But I
yes.
think Ankafo prison, they have the TB,
The
infectious whatever
unit.
unit there.
They've been doing TB screening most often there, and they are managing. So they isolate the TB patients
Yes.
who get infected, then they will isolate them to another special unit.
but
So-
the difficulty is that before they will even detect that the person has TB,
It must spread over
that's it,
thousands of them.
because of the confinement.
Okay.
But so
Last to add, we have some occupations that expose us. I've mentioned health workers. If you are working in a place that brings out dust or dust particles, so people who are working in the mines, who are working construction like sand winning,
Yes.
they inhale the dust and it punches holes into their lungs, making them susceptible to getting the TB infection. So you realize that somebody would have worked in the mines for a while, comes down with TB. Somebody is a construction worker or working with sand winning and those things. That's another, the occupational side of it.
when you wanted to say something, when you started, you gave a brief history about this TB, 18 something.
Yeah, that's when it was discovered.
Okay. So centuries.
Yeah.
So we are in 2026. So you mean to tell us that they've not gotten anything that will end this?
Okay.
Why is it
a problem?
A major public health concern in 2026, from 18 to 2026?
Okay. So thank you. So that draws us to the advances that we've made so far. At first, when somebody got TB, it was a death sentence. The person will go. Then they discovered what was actually causing it. Later on, they brought the drugs, and they named the drugs after the person who discovered the the bacteria. So you hear anticox. So TB drugs came inside. Then we've made advances towards diagnosis too. So at first it was difficult to diagnose somebody of TB because in the whole region or the whole district, only one hospital probably can diagnose TB. So you realize that then when you go to big hospitals, you have TB unit, or how do they call it? They will have some one of the ward far away from all the wards.
Communicable disease.
Then they will diagnose. That's if you have TB, no matter where you are, they will have to bring you there. Now we've decentralized it to the point that when you have TB, you don't need to be hospitalized. Your treatment is free. Your diagnosis is free. Where where you'll be treated, you don't need to come to hospital. You stay at home. You get somebody that you trust and who you respect. That when the person says something, you can. Then we'll register you as a TB patient. You stay at home, but then comes on regular basis to take the medication. these are the advancements that we've made. We've added gene expert, which is a timely one. At first, TB diagnosis used to take close to a week or more, depending on the load and all those things. Now, within 2 hours, we are able to tell whether you are suffering from TB or not. X-rays have come in, where after taking it, they look at the pattern in the chest to tell whether it's TB or not. We've had advancement in detecting even if somebody has been infected with drug-resistant type. We are able to tell that this is drug-resistant TB and this is what we should do. These are all the advances we've made. Now you've come to the point, why is it still a concern in 2026 after making all this investment? The main, and which points to my main issue, is that we have low detection. People are not reporting with the conditions. As I said, we are able to detect only 50%, actually less than 50% of the cases in Ghana. Now, if the hospital is well arranged, when you go to CHIPS compounds, they don't have the capacity to diagnose now. Some health centers have, but most hospitals have. So at least we are sure that if you go to a health center, they are able to diagnose. But people are not reporting. They are rather going to buy drugs from the pharmacies, then they will take, or herbal drugs, then they will take, or some go to sleep at spiritual camps. Then the time they will come, something that we can cure and it will go, the person will end up dying from it. That's why it's still a concern. So I don't know if I've been able to...
Yes, so are you looking forward to ending this?
Truly. So if you look at the since 2020 upwards, globally we've been using Yes We Can End TB as the theme for the World TB Days that we celebrate annually. The reason is that a strategy was built or drawn that we want to end TB by 2030. We are in 2026. 4 years left. Now, the Yes We Can indicates that yes, we have the capacity to do it and we should be able to do it. This year, they've added a small clause to it. It's led by countries, powered by people. The reason is why they're saying it's led by countries is because we know, let me quote myself well, we know very well what is going on globally. Donald Trump and others have cut down help to a lot of needy countries or developing countries where they are not sponsoring or paying for drugs and those things necessary. So it means the countries have to take charge of that responsibility to provide the drugs, the treatment, the diagnosis, and all those things. Now we the people are supposed to lead the charge in looking for the patients and treating them. And the patients themselves are supposed to be forthcoming. So we are on the way, hoping that 2030 we should end TB.
All right, you're still watching Cafdil Healthcare on Cafdil TV. We are discussing TB, and I know we've said a lot about that. And if you are not aware, now you are aware of certain things. We are going for a breather. When we come back, we'll continue our discussion. Stay tuned.
Tuberculosis, or TB, an infectious disease that may affect almost any tissue of the body, especially the lungs, caused by the organism Mycobacterium tuberculosis. About 10 million people worldwide were sick with TB in 2015, and about 1.8 million people died from TB worldwide in 2015, according to the World Health Organization. What are the causes of tuberculosis? All cases of TB are passed from person to person via droplets. When someone with TB infection coughs, sneezes, or talks, tiny droplets of saliva or mucus are expelled into the air, which can be inhaled by another person. Once infectious particles reach the alveoli, the small sac-like structures in the air spaces in the lungs, another cell called the macrophage engulfs the TB bacteria. Then the bacteria are transmitted to the lymphatic system and bloodstream and spread to other organs occurs. The bacteria further multiply in organs that have high oxygen pressures, such as the upper lobes of the lungs, the kidneys, bone marrow, and meninges, the membrane-like coverings of the brain and spinal cord. Latent TB. You have the germs in your body, but your immune system stops them from spreading. That means you don't have any symptoms and you're not contagious. But the infection is still alive in your body and can one day become active. Signs and symptoms. A cough that lasts more than 3 weeks. Chest pain. Coughing up blood. Feeling tired all the time. Night sweats. Chills. Fever. Loss of appetite. Weight loss. Diagnosis. During the physical exam, your doctor will check your lymph nodes for swelling and use a stethoscope to listen carefully to the sounds your lungs make while you breathe. Blood tests. Blood tests may be used to confirm or rule out latent or active tuberculosis. These tests are sophisticated technology to measure your immune system's reaction to TB bacteria. Imaging tests. If you've had a positive skin test, your doctor is likely to order a chest X-ray or a CT scan. This may show white spots in your lungs where your immune system has walled off TB bacteria, or it may reveal changes in your lungs caused by active tuberculosis. Sputum tests. If your chest X-ray shows signs of tuberculosis, your doctor may take samples of your sputum, the mucus that comes up when you cough. The samples are tested for TB bacteria. Treatment. With the proper treatment, tuberculosis is almost always curable. Doctors prescribe antibiotics to kill the bacteria that cause it. You'll need to take them for 6 to 9 months. What medications you take and how long you'll have to take them depends on which works to eradicate your TB. Sometimes antibiotics used to treat the disease don't work. Doctors call this drug-resistant TB. If you have this form of the disease, you may need to take stronger medications for longer. The main drugs for tuberculosis are ethambutol, isoniazid, pyrazinamide, rifampin.
Welcome back. This is Cafdil Healthcare on Cafdil TV, and we are still discussing TB, tuberculosis. You heard it not long ago. The whole world celebrated it, even though we say it is what do you call it? The disease of the past or of the old. But Massa, in 2020, it is still relevant, killing a lot of people. So let me come to you, Sandra. If someone was exposed to a person with active, because you say latent one, it doesn't show any symptoms. So active TB, what should the person do immediately?
Okay, so for that one, the main thing to help us rule out is screening, so that we can't do anything about it. It's not that the person is on some medication, so you also have to be on it. No, you just have to come for screening to be done to know if you have it. And sometimes too, we do contact tracing. Let's say
that was what I was going to ask. When now said that people are not reporting.
Yeah.
So from you, like I was going to ask me that when COVID came, you people were doing contact tracing. Yes. Why are you not doing the same thing now?
Yes, we are doing it. We are really, really doing it. So if I have TB and I report, or if I'm diagnosed of TB, what we do is we do contact tracing. So we trace your people, come to your home, number of people living, then we screen them. So you have contacts. So we screen those people to see if indeed they've gotten it or not. If we do the screening and we realize they don't have it, the doctor will determine whether we should give them some prophylaxis or not. So the contact tracing also helps. It goes up to you get a contact to someone with tuberculosis. So we do that to make sure people are not infected or it's not being spread in the community.
So how long does it take for someone who has been exposed to test positive?
It depends on the individual. It depends on the individual. It can take like a month, 2 or 3. So we always encourage regular screening to be done.
All right. So, Constance, tell us. Let's come to talk about the treatment. What is the standard treatment regime for active ones TB, and why is it so important for that patient to finish the entire course?
Okay, thank you. So with the standard regimen, we have the adults and the pediatric regimen. And they are all supposed to take the medication for at least 6 months. Within the 6 months, we divide it into two, which is the intensive phase and the continuation phase. The intensive phase is for 2 months.
Within the 6 months.
Within the 6 months. Okay. So the intensive phase is for 2 months, where we give a combination of drug called the rifampicin, pyrazinamide, ethambutol, and isoniazid. There are two different types of drugs we give. Some combinations are removed after 2 months.
Okay.
Yes. So during the intensive phase, the person is supposed to take it every day, depending on their weight.
Okay.
With the pediatrics too, like I said, it's the same medication, but because they are children, their dosage is reduced, and also given per the weight. So the one we give, or at least anyone can take about 2 tablets or 4 tablets. No one takes more than 2, less than 2
a day.
A day.
Okay.
No one takes less than 2 or more than 4.
Okay.
Depending on their weight. And so they take the first during the intensive phase for 2 months, and then after 2 months, 2 of the drugs are taken out, remaining 2. And that is after they've been tested again to see if it's okay to continue to the continuation phase.
All right.
Yes. But with some of the infections, like the one that affects the bone and the spine, that one, the treatment is usually difficult. So they have, per the doctor's assessment, they may decide to extend it to 8 months or 1 year.
Why? Why difficult?
Because it's not affecting the lungs. Yes, it has spread to some places where the treatment
in the bones and other locations.
The bones and the spine. Yes. So they will have to extend it to ensure that the bacteria is completely cleared from the system before they can. Yes.
So this course, why should I? Because some of them, when you take the medicine 1, 2, 3 days, 4 days, and they see okay, 6 months, I cannot, then the person may stop. So why is it important to finish the whole course?
It's important because in Akan language they say "emwanubesro." So you become resistant to the medication you are taking. And when you are resistant, treatment becomes very difficult. And that's why some of them end up dying. Okay, so it's important that they continue the regimen as prescribed to be able to clear the the bacteria completely. Yes.
So if you stop early, you may die.
You may not die, but the treatment becomes difficult. Okay, because now bacteria abuano washo. Okay.
And with the drug resistance, some people also contract the bacteria. We have TB and then we have drug resistance. I can contract the drug resistance from the patient direct.
How?
Okay, so she is TB patient on medication. She didn't comply with the medication, so the body has built resistance.
Okay.
So now it has turned to another stage whereby the treatment is totally different from the normal TB. So this person can give somebody drug-resistant TB depending on what he or she is harboring.
Okay.
So I can contract the resistant TB from her direct.
Okay.
So I'll come to the hospital and I'll be diagnosed of drug-resistant TB. Whilst I didn't get TB before.
Okay. Oh, all right. Right. So now,
yes.
I am very optimistic that every medicine has its own side effect.
Sure.
So tell us, with this medicine that Constance mentioned, does it have side effects, and what are they? And how do we even manage
The side effects.
with those
Okay.
things?
So just like you said, every drug comes with side effects. But then the side effect is not general to everyone. The way I might react will be entirely different from how you will react.
Sure, because my immune system are very strong.
Surely. So the issue is this. When somebody is taking the TB drugs, there are some mild, it's actually very safe. It's safe because most people, they don't experience any problem. But these are just the few things. The color of the drug itself is reddish or yellowy, so mostly reddish in color. I have color blindness, so I'm not, but so it's mostly reddish in color. So when the person starts to take it, their urine color changes.
Okay.
It becomes orange to reddish. It takes the color of the drug. It's not something bad. It is just part of the pharmacological process. So it's something that will clear when we switch the person out of that particular drug. It's not that we should stop it.
Okay.
No, it's something that will continue. After the 2 months and we switch, the urine clears off. Now, in some individuals, I've noticed that, or we've noticed, some people can react to a particular drug inside. You know, we said 4 drugs in one. Somebody can react to one of the drugs inside there. It can cause the person to have severe headache. So when it comes to that point, and we realize that, okay, it's when you take the drugs, then you have this headache. We will provide you separate, not combined, separate drugs. Take this one, then let's see. Take this one, let's see. Then we identify the particular one that is triggering the headache.
Okay.
Then we give a substitute of
That one.
So that's how it is. But on a general, most people don't experience. Some can also say when they start taking, they feel itchiness, like itchy skin, or they experience itchiness. It's normal. It's something that, so they usually add what's the name, Baradozin to it. So whilst it's just another drug they add to reduce the side effect of it. But basically, these are the main issues that nobody actually reports severe side effects as much that are frequency.
That's good to hear. Our time is drawing closer, and so we have to wrap up and see. But before that, Constance, what measures can we put in place, in order to protect ourselves, both health workers, both individuals, anybody? How are we going to do that so that the spread will at least reduce?
So it is important that we ensure adequate ventilation in the areas that we are.
Adequate ventilation.
Adequate ventilation.
Okay.
Where there's a very good exchange of air in and out of the room where we are. And also when we are around people we suspect to have the disease, we have to ensure that we are well protected by wearing our PPEs, especially our face mask. And not just any mask, but our N95.
How does it look like?
That one is for health workers.
The health workers.
But what about us?
It's normal face mask.
You wear your normal face mask.
The one like a cup.
Yeah.
Oh, I have about 3 there. I have about. You see, when COVID came, I wasn't using any nose mask. I was free 24/7.
Oh, okay.
So all those that they gave me, I still there, kept. Yes.
Yeah, you're holding.
So we are going. Let me start from you. Your last words. We are going.
So I'll say TB is highly curable, and yes, we can, and it is a shared responsibility. If you have it, just comply, and if you don't have it, just take or make sure you do regular screening to prevent TB.
All right. Now,
Yeah, I would just want to add that we've said everything about TB is free. So if you're experiencing signs and symptoms of it, go to the hospital near you. They'll screen you. If it demands that you should be treated, it doesn't require you to have health insurance. You'll be treated, and it's curable too. So don't go and stay at a prayer camp. Bring the person, the prayer leader, to the hospital. We can initiate you. Take the drugs whilst praying as well in the prayer camp. We can do both.
Hey, now.
Yes.
Yes.
Constance.
Okay, I would also say that TB is not a death warrant and it's not a curse. It is transmitted by bacteria. And so when you have it, quickly come to the hospital to be screened and treated. And also for those in the communities, please stop discriminating against people with TB. We should all try to support them and help them recover.
That's very important. Stop discriminating.
Stigma.
That is very important. And stigmatizing people like those patients. Very, very important. Please, let's stop. Let's get closer to them. Let's encourage them. And also go to hospital regularly to test yours. Maybe you may have the latent one. Also, all of us are going to test, actually. Thanks for coming. So you heard Peter Nab is a disease control officer, Cape Coast Teaching Hospital. Sandra Adai, also public health nurse, Cape Coast Teaching Hospital. And Constant
Abuga.
Also senior staff nurse and infectious disease unit, Cape Coast Teaching Hospital. Thank you, wonderful producer. He has been sitting in for me all this while. God bless you. God bless all my camera. Hey, Makati. My name is Kojo. At the same time next week, God be with you. Bye-bye.